Dr. Nada, can you tell us a little bit more about lung malformation?
Yes, lung malformation encompasses a lot of different conditions that involve the airway of the lung or the lung tissue itself. The issue with the lung malformation is a congenital problem whereby they are born with the problem, and is associated with the formation of the lung. So a lung forms from an initial tube that divides to the lung and the airway forward, and the esophagus, which is the food pipe at the back. So somewhere along the way where the lung divides from the esophagus and then forms lung buds and then form proper lungs. The right side has got 3 lobes, left side has got 2 lobes. Somewhere along the way there is a problem, therefore that causes different types of lung malformation. So if the problem happens very early on, where there is a problem during the bud stage of the lung malformation, they can form a cyst instead of a proper lung. And those cysts, which are usually sitting in the airway, the big airway, the trachea or the bronchus, those are called bronchogenic cysts. Abnormalities that form within the lung, the commonest one is something called CPAM, congenital pulmonary airway malformation, and that's basically mean abnormality of the lung tissue. They can be cystic, where there is multiple areas of cyst, or it can be solid, where the whole area is thickened. That condition is due to abnormalities during the formation of the airway, smaller airway, the bronchus. So if you imagine the airway is made of the trachea, and then it divides into right and left bronchus, and then subsequently into smaller bronchi. During the formation of the smaller bronchi, if there is an abnormality at that stage, they can have formation of cysts instead of proper lung tissue. The lung tissue at the end of this bronchus is are alveoli. Alveoli are little sacs of tissue which can contain air, and they are like sponge-like. And the cystic malformation or CPAMs are larger cysts, or they can sometimes be solid tissue because the bronchus hasn't formed properly. So at that stage of the development, there's something else called sequestration, whereby a lung bud has formed, an abnormal lung bud has formed that is separate from the lung, and it's not connected to the rest of the lung by the airway. So there's only blood vessels connecting to those sequestration, but not usually connected by the airway tissue. So those are the various different types of lung malformations.
As a congenital defect or malformation, this is something that would be immediately obvious at birth, or is this something that may not be readily identifiable until a little later on?
So more and more we are identifying these lung malformation antenatally. So in the past, these were not picked up. Until about 10 years ago, they are more, the ultrasound technology is much better, and these malformations are picked up more and more. The issue with this we'll mention in a minute, but the issue with lung malformation is that the denominator of how many of these malformations occurred in the past is not known. In the past, we only find out about the malformation if there is a problem, and the usual problems are if a child has an infection, because there are cystic areas in the lung, they will pool mucus, and stagnant mucus have a higher chance of getting infected, and that's one way of identifying those in the past. And secondly, if the cyst is very superficial on the lung tissue, it can leak air. So the air can leak into the chest space and cause something called pneumothorax. That's also a very rare occurrence, but that's a second way of identifying this in the past, before we identify them which is currently the most common way of identifying lung malformation, is the antenatal period.
Understand. But if for example, the antenatal scans are not done or are not done well or not interpreted well, when the baby is born, what are the symptoms that would occur which would indicate possible lung malformation?
So if there is a lung malformation not picked up antenatally, as I said, the times that they are identified are when they have infection, or they have this pneumothorax where there's a leak of air from the cystic area into the chest space, or very rarely they can get tumors, and these tumors are quite aggressive. The vast majority of tumors are identified when they are much older, at 40 or 50 years of age, and these tumors, when they are identified, taken out during surgery in an older patient, they are found to have cystic areas, which suggests that the cystic malformation had transformed to cancers in later life.
Right.
So those are the three main ways of identifying lung malformation in patients in the past.
And when it comes to, once you've identified lung malformation, what are the kind of interventions that would take place?
So if you identify and normally antenatally, the child is usually allowed to be born in a normal state, whichever parents choose. It could be a vaginal delivery or a cesarean section. It doesn't make too much of a difference. The child is then monitored, usually in a pediatric surgical center, where the child is observed for the first few days. A simple X-ray is done to identify whether there's an obvious abnormality on a simple X-ray. Simple X-ray doesn't always show up an anomaly, because it's very these anomalies are best identified with a 3D scan, like a CT scan or MRI scan. So once a child is born, we may not see any symptoms, which is often the case, and then the child is left home. And after a few months, I usually request for a CT scan to be done on these children at about 3 or 4 months of age, at which time the child is more robust and more mature, and at that stage we can assess the degree of abnormality and the type of abnormality. They are the cystic forms, where they are cysts, different sizes of cysts, and also the more solid forms of this CPAM. In regards to CPAM, if most of the patients or the babies are identified as having this lung malformation at the antenatal stage, so subsequently the child will be born, a simple X-ray is done to see if there is an obvious abnormality, whether there's something called pneumothorax, where the air has leaked out into the chest cavity, or the size of the abnormality. If the size is glaringly huge, then the child may need some sort of intervention when they are newborn, or if there's any symptoms, child having difficulty breathing, or the CPAM is causing restriction of the rest of the good lung from expanding. So those are the rare occasions of having to intervene at that stage. Most children are let home early, within a few days after they are born, and they're followed up by a CT scan at about 3 or 4 months of age. At this stage, we'll assess the CPAM, see what kind of abnormality it is, whether it's cystic or solid type. The cystic type, there are various different forms ranging from smaller cysts to larger cysts. The larger cysts are the ones that may cause problems, both with infection and also pneumothoraces, and also they are also associated with higher incidences of cancer formation. The incidence of cancer formation can be any time during their lifetime. We've identified children, or there's a report of children having cancers as early as 1.5 years of age. So to avoid any complications, we tend to remove the larger cyst CPAMs. In terms of the solid CPAMs, they may not cause any issues unless it's a large solid mass, causing restriction to the movement of the normal lung. If that's the case, then that's an indication to intervene surgically. So the intervention that I propose, I do regularly, is the thoracoscopic or keyhole surgery to remove the abnormal lung. Most children who have surgery to remove the lungs, the abnormal lung, are asymptomatic, which means that they have no symptoms at all. The benefit of removing the abnormal lung is that you avoid complications. The complications are infection, which is about 5 to 10% of cases, pneumothoraces, which is very rare, and cancer formation. Again, the incidence is roughly about 5%. So to avoid that, we remove the lung. And also, we do not know what happens in the long term, what these abnormal lungs with a cystic malformation would behave like later on, because there's no long-term follow-up that's been described in the literature. So to avoid any of these complications, especially tumor formation, which is a very serious issue, we remove the lungs.
The entire lung?
We remove the lobe. Usually,
right.
If you consider the lung, the right side there are 3 lobes, and the left side there are 2 lobes. So most often there's only 1 lobe involved, so we can safely remove 1 lobe. And by removing the lobe at about 10 months of age, or at the weight of about 8 kilos, the other parts of the lung which are there would compensate and grow to cover up the chest space that's there. And the benefit of doing it early is that the child still has growth developmental process or potential of developing new lung, as opposed to just enlarging in size, because the development of lung is not complete up to the age of 2. So they've got something called stem cells still going on, still differentiating and growing. So if you do remove part of the lung or a single lobe, then the other 2 lobes on the right side would just compensate and grow as to cover up whatever that's missing. So that's the benefit of doing it early. And if you do an operation and 2 years later you do perform an X-ray, the X-ray would look like completely normal X-ray. The benefit of doing keyhole surgery is that the child recovers quickly. Tiny cuts, there's hardly any pain afterwards. They recover within 2 or 3 days, they're out of the hospital. And the purpose of doing a keyhole surgery is that we don't cut any muscle, and there's no skeletal deformity or differential pull of the muscle, right versus left, and causing any vertebral abnormalities, which is the spine at the back. So if you have abnormality of the chest wall on one side, you may tilt the vertebra to one side or the other.
Okay. Thank you, Doctor.